afternoon, everyone, and welcome to MRF HIV STI Echo Series 5. Today's topic is mental health and HIV, the need for an integrated response. And our presenter today is Professor Lydia Chwastiak. She is adjunct professor of global health, of psychiatry and behavioral sciences, and she holds the Many Minds Collaborative Endowed Professorship in behavioral health, psychiatry, and behavioral sciences at the University of Washington. Over the past 18 years, her research has focused on improving the medical care and medical outcomes among individuals with schizophrenia and other serious mental illnesses. And her research focus is on the complex intersection of chronic medical illnesses and serious mental illnesses. She has co-authored or authored more than 60 peer-reviewed publications related to the epidemiology and treatment of cardiovascular risk factors with, among patients with serious mental illness. So we are tremendously privileged to have Professor Chwastiak with us. And thank you, Professor Chwastiak, for agreeing to assist us. And I turn the floor over to you.
Yeah, thanks very much. I'm delighted to be here. And I'm very excited that this topic is being included in the ECHO series. Let me just go ahead and share my screen, share my slides so I can get started. Okay. Does that look okay to everyone?
Yes, that's great.
Yeah, great. Okay. So I'm really delighted to be here. As Greg mentioned, I'm a psychiatrist. I'm also an internal medicine physician, and I've done a lot of research on integrated care over the last 20 or more years. But my clinical work too has been as a psychiatrist in primary care and HIV clinical settings. And so I'm really excited to talk about this topic today with your audience in particular. I'm working with one of my roles at the University of Washington is in iTech, and I am the principal investigator of a grant that supports the work that's being done by Conrad and Alana and the team. And so just really excited to be part of today's discussion. I think I was supposed to show this acknowledgement slide. I personally have no conflicts to disclose. So, kind of thinking about the clinical work of integrating mental health care and HIV care, really wanted to have a couple of objectives for the didactic portion of today, really at a high level, just to kind of review the epidemiology and impact of mental disorders on people living with or at risk for HIV. Which should be a review. I think this is familiar to those of you who are doing the work. It isn't news about the increased prevalence of these disorders in these populations. But I wanted to talk a little bit about how integrated care models can help address what's come to be known as the mental health treatment gap, the difference between the group of people who are living with disorders and the group who are receiving effective treatment, and really talk about some of the innovative work that's been done over the last decade or so to bring services together. And then to really sort of bring it closer to home and think about your own clinical settings. And I hope we'll have a chance for a discussion at the end and questions around thinking about strategies to expand mental health services that are integrated into your own clinical settings. And I know Belinda's been doing a lot of work working with HACU and with the team around thinking about ways to optimize service delivery. So I'd love to hear more about that. So just by way of background, to remind everyone just how common mental disorders are. And when we think about data that comes out of WHO and the global burden of disease, that almost 1 billion people in the world are living with a mental disorder. And that's 16% of the global population. And I think it's a helpful reminder about how common mental disorders are. So when you think about your practice every day, the number of patients who come in, whether we're aware of it or not, there are a lot of people coming into primary care and HIV care settings who are experiencing a mental disorder. And, some of the numbers that come out of the most recent global burden of disease reflect, the more serious disorders like schizophrenia and bipolar disorder being less common, but that when we talk about efforts to integrate care into primary care and HIV care settings. We really want to focus today on thinking about the more common mental disorders, depression, anxiety, alcohol use disorder. So we can kind of think about how the models work across all disorders, but that most of the literature, most of the research literature is really focused on the more common mental disorders. So that's what I'll be kind of focusing on. What we can kind of think about, epidemiologists, researchers, the World Health Organization, kind of broadly, can think about the impact of mental disorders from a number of perspectives. One is, just sheer numbers, just the slide that I just showed you, that almost 1 billion people in the world have a mental disorder. We can also think about costs, economic costs of depression. For example, of depression, it's been estimated that depression is associated with with costs of over $1 trillion per year to the global economy. And when we think about depression, I think there's something different about mental disorders and substance use disorders from some of the medical conditions, the chronic medical conditions that were primarily responsible for managing in primary care, in that they're very expensive disorders, but the costs are not really associated with a lot of expensive treatments or a lot of inpatient care that drives the cost, these direct costs. They're actually largely driven by indirect costs. So people being unable to work, people being unable to finish school or missing work or being less productive at work. So it's these kind of societal costs that are tremendously burdensome to societies. And so as WHO shifted, I don't know, maybe 25 years ago, excuse me, from focusing on mortality data to thinking about the global burden of disease, having countries talk about, report data on chronic conditions and disability, that this is actually a major public health issue, to think about disability associated with disorders. What's come to be recognized is that depression is the second leading cause of years lived with disability. And what the figure illustrates, the primary reason why depression and other mental disorders are associated with so much disability. And this is because when we think about chronic disorders, things like hypertension, diabetes, these typically have an onset later in life. So people are experiencing hypertension, cardiovascular disease, 40s, 50s, 60s. But mental disorders have a very early age of onset. And in fact, 75% of mental disorders will develop by the age of 24. And half mental disorders will have the onset before age 14. So that really ends up with people from a young age living with some disability and then experiencing disability throughout a number of years of life. And I think this is really why the focus on early identification and early intervention is so important, so that we can mitigate some of that disability, improve some of those outcomes, and mitigate some of that disability. And another reason why adolescents living with HIV are a key population for us to be concerned about, because rates of depression and other mental disorders among adolescents with HIV are quite high. This is a population at great risk for mental disorders. So as I mentioned, kind of thinking about the epidemiology of depression, there's sort of the global numbers, rates of maybe 10, 15% of the population is experiencing depression. But when we look at people with chronic diseases, in particular HIV, rates of depression are more than twice that of the general population. And so, this is a particularly important topic. And we think about, just kind of general primary care settings, want to be thinking about depression, that it's very common, but among people living with HIV, it's like in most settings, it's twice as common. And again, adolescents, very high risk, and older adults living with HIV also at higher risk. And as we, it's sort of beyond depression that some of the statistics that have come out of, ministries of health or research studies have suggested that rates of PTSD and trauma in particular are much, much higher among people living with HIV compared to the general population. And a particularly alarming statistic is the much higher rate of death by suicide compared to the general population. So really very significant consequences of missing these diagnoses, letting diagnoses be unaddressed, not identified and not addressed. I included the figure in this slide, the figure on the right hand of the slide, to just be clear about what how you as physicians working in primary care or working in HIV care settings might think about sort of a population approach to depression, right? I think a lot of people, a lot of lay people, even a lot of staff and providers who work in clinics, they think of mental illness, mental disorders, and their minds go right to very serious mental disorders. These are people, people who are in the hospital or have psychosis. And, how could we ever manage that in primary care? That's just not appropriate for us to manage in primary care. And so these are data actually from a hospital system in Ethiopia, but the numbers are the same in settings here in the US. They're the same in settings, kind of around the world. When we think about sort of the distribution of severity of depression symptoms that this is among people living with a clinical sample of people living with HIV, the rates of depression could be as high as 50% or higher. So, we're actually seeing a fair number of people who are experiencing some depression symptoms. But the vast majority of people are experiencing minimal to mild depression. And, mild depression, that's sort of the 8% with mild depression and the 4.5% with moderate depression. This is really what we think of clinically significant depression. So we've got a lot of people who are being impacted by symptoms who could improve and function better with very minimal intervention. So, the tail end of this figure where we have 2% of people with severe depression who experience suicidality or may need hospitalization, these patients are always going to need care of specialists and care in specialty settings. But it's really this group of the much larger group with minimal to mild depression is what we're talking about, sort of identifying and addressing within primary care settings. Just to kind of place the data that has come out of Trinidad and Tobago within, to kind of compare it to what I've just presented about global data, it's pretty similar. So we see there's a study that was conducted in 28 family practices, screening for depression. And so looking at about a 13% prevalence rate of current depression. So that's about kind of what the global burden of disease study shows, or what we see in the US or Western Europe. This study showed particular risk among younger patients, those who had lower educational status, those who did not have social support or were not in a relationship. But we see sort of a similar pattern in studies that have come out of Trinidad, that we've got a sort of a population rate of about 12%. But if you go into chronic disease clinics, rates are much higher. So, more than a quarter of patients have clinically significant depression. And then within inpatient settings, acute hospital settings, this is an older study now, it's almost 20 years old, but people who were living with HIV who were in an acute hospital setting, almost half of them were experiencing depression. So it's something that you'll see in your practice, I guess, is maybe, kind of heavy-handed way to make the point, but very, very common. And the reason, I think there's two primary reasons why we want to think about identifying and addressing mental disorders in the care of people living with HIV in primary care or specialty settings. One is, the argument that I just made about the impact on society and people's functioning, their ability to work, their ability to have quality of life. It's a good in itself to have people have our patients have improved mental health. But relevant to the topic today is to really acknowledge the impact of mental disorders on every phase of the HIV care cascade. And there's been a lot of data that shows that mental illness contributes to somewhere between a 4 to 10 times increased risk of acquiring HIV. And then as we look at every stage in every phase in the care cascade, people who are experiencing mental disorders will have a delay in being tested and being identified. Once they're identified, a delay in linkage to care, on and on, reduced retention in care, reduced adherence to antiretrovirals. So really thinking about the importance of identifying mental disorders and providing adequate treatment for mental disorders so we can achieve the goals of ending the HIV epidemic. So this slide actually presents some really interesting data, some of the strongest data that really shows how depression leads to poor HIV outcomes. So I'll just try to walk you through. This is a study that was done by Brian Pence's group. He's at University of North Carolina in the US. And this study followed, or he led this, it was a large group of investigators. It was a big study of 6,000 people, US adults who were living with HIV, who were followed for up to 10 years. So they would identify these clinical samples, and then people were surveyed twice a year for up to 10 years. And one of the interesting findings related to depression in this sample, they looked at two separate studies from this cohort. Looked at first, what was the impact of depression on antiretroviral adherence and virologic failure to be virally suppressed. And then a second study looked at mortality. And so when we look at the table and think about adherence and virologic failure, what the investigators did was to compare people who had no depression throughout their time of follow-up to those who were depressed for about a quarter of the time of follow-up, to those who were depressed throughout their entire time of follow-up. And you can see in the table that both antiretroviral non-adherence and virologic failure were both significantly increased among those who were even depressed just a quarter of the time, and a much higher odds ratio of not being virally suppressed or being non-adherent if they were depressed most of the time, all of the time of their follow-up. And sort of equally concerning or also concerning was sort of the findings related to mortality, and showing that a significant hazard ratio associated with experiencing of depression. So depression leading to increased mortality among people living with HIV. So, how are we doing then, given the importance of identifying and treating depression among the people we're caring for? We're actually not doing a great job in terms of recognizing people clinically and making sure people receive appropriate and adequate treatment so that they achieve remission of their depression. And so this is data from a large study that was published now 12 years ago that basically shows in clinical samples that of all the people with HIV who are living with depression, only 40% of them are recognized clinically. So we're already starting with more than half the people who are living with depression are not recognized. And then of those who are recognized clinically, only a subgroup receive any treatment, a smaller subgroup receive adequate treatment. So we're looking at only 15% of people who are living with depression are achieving remission. And it's sort of disappointing and frustrating. These are data published more than 12 years ago, that our numbers are really not, despite our best efforts, our numbers are not that much better with kind of the efforts that we have to date of not systematic screening, not supporting referrals, not integrating care into settings. So this has led UNAIDS and a number of the World Health Organization to make specific recommendations about integrating mental health care and HIV care. And I think there have been, over the last decade or so, there have been a number of recommendations about, care should be integrated. Here's all this research literature about the effectiveness of integrated care models. Programs, clinics should just do this. Ministries of health should implement these models. But the recent Global AIDS Strategy for 2021 through 2026 actually has a specific target for the integration of HIV and mental health. And I I think everyone's probably aware of this, but really kind of thinking about it in your own practice, that the target is that 90% of people who are living with HIV be linked to person-centered, context-specific services, not only for HIV, but also for NCDs, gender-based violence, and mental health. So really thinking about, are we reaching 90% of people with effective mental health services? And so I think this leads to the question of how do we reach people? How do we reach people with services? How do we connect people to services? What are the best models of care, given, we've got primary care, medical settings, HIV specialty settings, medical care is being provided there. What are the options for providing mental health services? And so this is the figure on the left hand of this slide is from the World Health Organization, and they have this wonderful pyramid of the optimal mix of mental health services, right? So the vast majority of people kind of are at the bottom of the pyramid. We have people, again, this is the people with minimal to mild symptoms, a lot of self-care, self-management, informal family care, community care. And at the top of the pyramid, much, much smaller group of people who really need inpatient care, long-term special care by specialists. So it's the group in the middle that I think is our interesting opportunity to have innovative models and to intervene differently. And those are people who can be treated within primary care-based services, within general hospitals, kind of thinking about how can care be provided within other parts of the healthcare system. And so as I alluded to, there's been a vast literature on integrated care models that date to the 1990s, that, probably over 100 clinical trials that show that integrated care, reduces care fragmentation. You're literally bringing mental health services into medical settings. So it increases access to high quality mental health services. And one of the mechanisms for this is to decrease perceived stigma, to people feel more comfortable coming to their medical setting as opposed to going to a specialty mental health setting. And then there has been literature specifically in HIV care settings. If we bring mental health services into HIV care settings, that this can actually improve HIV treatment adherence and retention in HIV care. So I wanted to just highlight, talk for a minute, kind of the how to do this is really based largely on some guidelines that WHO developed probably, I don't know, 2012 or 2013, called the MH-Gap Intervention Guide. Recognition, again, of this mental health treatment gap. We have a lot of people living with mental disorders and very few who are getting any treatment and far fewer who are getting effective treatment. So there's so WHO developed a guide specifically for the management of priority mental disorders within primary care and secondary medical settings that include workflows, protocols, kind of SOPs around assessment, management, and follow-up. So we can talk about these. Many of you may be familiar with this, but we can talk about this in the discussion and talk about how the implementation of these guidelines has worked. But essentially, what the MH-Gap and what any sort of integrated care model proposes as a workflow is that there's a need to identify and engage people who may have a mental disorder, to establish a diagnosis so that a treatment plan can be formulated, to initiate treatment, and then importantly, to follow up treatment to the point of remission. I think this is where things fall off in primary care. I mean, things fall off at every stage, but in particular, physicians often think that just by initiating treatment, by prescribing an antidepressant medication, that the work is over and that they've addressed depression. And so one of the main points I want to emphasize today is this idea of the need for structured follow-up and assessing to remission. And then thinking about, once people are in remission, how do you prevent a relapse or a recurrence? And, starting this kind of workflow around screening, is, a question I think that in the I was a primary care provider, and then as I became a psychiatrist, working in primary care clinics as a psychiatrist, seeing patients for my primary care colleagues, I think a lot of us feel like we do a pretty good job. We have great clinical skills. We know who's depressed. We know how to treat depression. That's pretty straightforward. And I think the reality is we're not as good as we think we are, and we miss a lot of people. And the numbers show that, right? That we're only picking up about 40% of people. And this quote really struck with me. This is, there was a needs assessment that was done by CTEC, ITEC's, our Trinidad team's colleagues in Jamaica, had conducted an assessment of their mental health and substance use services a couple of years ago. And there was a quote in that needs assessment that really struck me. It was from a person who was receiving HIV's clinical services. And this person said that the system deems me as doing fine because I'm adherent with my medication, so they ignore my mental health needs. I've never seen a psychologist or a social worker at the clinic, but I have had depression. And my life isn't just about viral suppression, but about quality of life. And I think it highlights how at a systems level, an organizational level, we've been really focused on, we have to end the epidemic. We have to engage people who are lost to follow up, people who are not virally suppressed. Let's screen them for depression. Let's put all of our efforts into people who are not doing well. And the reality is, there are people out there who are really suffering and struggling at in jobs, trying to take care of their kids, trying to be good spouses, and we're missing them if we don't screen. So to think a little bit about screening, we always try to encourage our primary care providers to think about depression screening, anxiety screening. It's kind of like you think about vital signs, that if you take a blood pressure when people come into the clinic, and you're looking to see, is there a problem? Is this an elevated blood pressure today? Is this someone who has essential hypertension and might need medication? So you're trying to identify if there's a problem, assessing whether there's kind of a need for further workup. And then if you do diagnose hypertension, you think, oh, how are they? You check the blood pressure in an ongoing way. Oh, are they well controlled? Do I need to change the treatment plan? So really getting into the habit of thinking about depression and anxiety monitoring like you think about blood pressure monitoring. And the tools, I hope these are familiar to you. I'm sort of interested in your experience with working with any of these tools. But there are a number of different tools to screen for depression. And two of the most widely used one are the Patient Health Questionnaire 2 and the GAD-2 for anxiety. So the Patient Health Questionnaire, the PHQ-2, the PHQ-9 is a widely used, validated clinical measure of depression. It's the 9 symptoms of depression, and their clinical thresholds of a score higher than 10 indicates clinically significant depression and the need for treatment. But in a lot of clinics, they just start with kind of annual screening with these first two questions, because if people don't endorse one or more of these questions, they would not meet the criteria for a major depressive episode. So this is a very widely used and helpful tool and short. And as we think about using tools like the PHQ-2 and the GAD-2, again, they're really just ways to have objective assessment, to identify improvement or worsening, but they also help create a common language around symptoms. So instead of this sort of impressionistic, they look sad to me, or I'm not sure if it's just grief, that it really is, the questions are the same every time. If you see someone and a month later a colleague sees them or a nurse sees them in between, you have kind of the same language to talk about what you're noticing, what you think might be clinical depression. And the flexibility of administration is a strength. They're self-report measures, but they can be done on the phone. They can be integrated into medical records. So they're very easy to use. Just, given the audience of physicians, I think you sort of think about your own setting and who might be doing the screening, for depression? Is this something that you would have to do in your own workflow, or is there someone else who might do the screening with the PHQ-2? But the PHQ-9 typically comes down to the physician to either do the PHQ-9 or to interpret it and try to think about the differential diagnosis, and is this a major depressive episode? And so a lot of the work that we've done with our own physicians and our own hospital systems is really coaching people how to talk about the PHQ-9. I think there's a couple of issues that come up. You know, primary care physicians are very busy. They have very brief, they don't have a lot of time with patients. There's a lot of concern that, you know, if they talk about depression, that you know, it'll just everybody will be overwhelmed and the visit will be 2 hours long. So really trying to find a way to help support physicians to talk about depression symptoms matter-of-factly, to be able to consider, is this something that needs treatment, and to think about a treatment plan. And so there are ways of just bringing up a conversation around depression, because the vast majority of people who are experiencing depression come to primary care, and very few people will say, you know, I'm very depressed. I would like to have depression treatment. The vast majority of people will come in with somatic symptoms, not doing well, changes in functioning, not managing their chronic illness well, and it really is helpful to just have one of these validated scales to just talk through depression symptoms and see whether that may be the cause of what's going on or a contributing factor. And we also encourage our primary care physicians to just be familiar with the range of mental health treatment therapies, and to be able to talk with patients. If you think depression is what's causing the person's symptoms, to be able to talk with them about, I can offer you medications, or I can offer you referral to psychotherapy, group therapy, family interventions. That these are to be aware of the resources that are available either within your clinical setting or on a referral basis, and be able to talk with people and help them access resources. And we do want to think about, you know, all kinds of treatment options, the evidence-based medications, any kind of psychotherapeutic intervention, a brief psychotherapy, even a brief psychological intervention, and then thinking about social support. So again, you're thinking, you know, the role of the physician is to identify depression, make a diagnosis, and really help to initiate the treatment plan. And as we think about pharmacologic management, and the MHGAP is very helpful in kind of supporting physicians through kind of on a point-by-point basis, about starting with psychoeducation, thinking about first-line medication for treatment of depression or anxiety, you know, thinking again about who's the person in front of me, do they have risk factors for side effects, do we want to think about sensitivity to medication, starting at a lower dose. As you're, once you've made a diagnosis, to begin treatment kind of starts with educating someone about the illness, presenting treatment options, and considering any factors that might lead you to pick one medication over another or start at a different dose than is the standard starting dose. It also helps, the MHGAP guidelines also help think about help you think through how long somebody may need treatment. And the general recommendation is for an acute major depressive episode to treat for 9 to 12 months. And so really talking with people about, this is what they should expect, this is the kind of follow-up they would receive, this is what would happen if they're not getting better, this is how long they might need to take Medicare, we would recommend that you take medication. All of those things, you know, are sort of part of initiating treatment. And when I say psychoeducation, I mean, I think this is something that people think psychologists do or therapists do. It's something that, you know, any healthcare worker can do or peer can do. You're really trying to explain the nature of the illness and talking about how these are often chronic illnesses. So symptoms can recur. And when they do, you know, what's the plan? When would you return? What are kind of strategies if symptoms are worsening? And really trying to get people to maintain a healthy life, to kind of avoid social withdrawal, stay engaged in social activities, think about their network around family and social support, avoiding alcohol and cannabis use, and just in general, kind of a healthy lifestyle. And these are things, we're doing in primary care anyway, kind of talking about sleep and eating well, kind of a healthy diet, physical activity. So just expanding though that sort of list of things that you talk with people around sort of a healthy lifestyle to include things like social connection or time in nature or something like meditation that can be really helpful in reducing anxiety. So this slide is just a list of all of the brief psychological interventions that the World Health Organization recommends. You can see a number of them are for depression. And I know Belinda's been working and training groups of providers and clinics on some of these interventions. But the point of this slide is to show that there are a number of these. Some of them are really very straightforward. They're all evidence-based for improving depression and anxiety symptoms. And so thinking about what are the resources within a given clinical setting, how could this be provided? Who would be the staff person to provide them? How could something like behavioral activation for depression be integrated into the current workflow? Or motivational interviewing for alcohol use disorder? How can we think about the work that we're currently doing, our current clinical protocols? How can this be part of what the team's already doing? So just a couple of words as we think about, so integrated care generally is is literally bringing behavioral health services into a medical setting. They're now, people are not going outside of the setting to get behavioral health care. And so there's a number of ways that this can be done, a number of effective ways that this can be done. And they are very, these models can look very different from each other. And they're driven by what any particular clinic or organization would provide would be driven by resources, staffing. I mean, there's a lot of factors that go into how an organization or a clinic or Ministry of Health, local Ministry of Health would decide how to integrate care. But there's a helpful rubric that Leo Cabillos and colleagues wrote. They did a systematic review that was published a couple of years ago that reviewed effective treatments for depression or alcohol use disorder in low and middle income countries. And they kind of went through all the literature. These are the models. This is, kind of the evidence of effectiveness, and found, I don't know, probably 20 different models that were effective. But one of the things that was helpful about this review was they had this approach to how they categorized models of integrated care. And that started from very basic, you've got a healthcare setting where there's a physician and or a nurse, could be very minimal staffing. But if you provide some kind of general mental health training for the people who are already providing the medical care, that they then either provide medication management or some kind of brief psychological intervention, that is, kind of one level of integrated care. You've got the healthcare workers doing both. They're continuing to provide medical care, and now they're also providing mental health care. Kind of a level of complexity that requires an additional resource is a consultation liaison model, in which you still have these physicians and nurses working in the clinic. They're now providing care, but now they have access to a psychiatrist. And so they can, so if a physician is seeing a patient, they can call a psychiatrist, they can connect to a psychiatrist through the medical record, through email, some strategy where physicians are providing treatment, but if they get stuck, they have a complex case, they can now get direct psychiatric consultation on a given case, direct for an individual case. So then the next kind of level of integrating care is to actually bring dedicated staff in to deliver care. So, again, you've got the staffing in the clinic, but now you want to deliver psychological interventions. And this can be, I think we typically think of psychologists as people who deliver therapy interventions, but These can be delivered by nurses, by social workers or case managers, or by lay health workers. And then once we have additional staff doing these evidence-based interventions, if we think about a stepped care approach, this is just kind of more of a process of care, that it's a structured approach driven by data to match the treatment intensity to the person's complexity of illness or severity of illness. So the figure is showing an example of a stepped care model, right? You've got people coming into clinic. You now have a lay health worker who's providing behavioral activation. So the person comes in, they're identified as having mild depression symptoms. They see the lay healthcare worker and they get support, psychoeducation, but they're not getting better. And so, most people will get better. So that's great. But it's the people who aren't getting better, because you're following them and they're not getting better. Those are the people who are sent to see the social worker, the psychologist, to receive the psychological intervention. And most of them will get better seeing the psychologist. But if they don't get better, they can see the physician to get medication and so on. So it's a really efficient way of using resources where, you kind of think about the WHO pyramid. People who can get better with minimal intervention get better. And the team's energy and resources are focused on people who are not getting better. So we think about kind of following the steps all the way up. If we're in the HIV care setting, we have options of kind of providing all the treatment within the care setting or referring out, which is much more typical and in kind of routine care in most places. And, we're all aware of the challenges of external referrals. I think it's in the literature, it's certainly in my clinical experience, that the vast majority of people who are referred from primary care to a specialty mental health center just, never make it to even a first appointment. There's shortages of specialists, there are wait times, there are a lot of logistical barriers, people who have to travel, that take time off from work, they don't have childcare, and then they're, just kind of stigma of going to a specialty mental health center. So I think one of the things that we can be thinking about as primary care providers, HIV care providers, is if we're continuing to have these pathways to specialty, who are the specialists we're referring to, and how can we strengthen those referral pathways to make it easier for people to support their engagement in that care. An alternative is to really try to bring everything into the medical clinic. And this is where the multidisciplinary team provides HIV and mental health and substance use care at that single site. And so it can be very structured. There's a range of these models, but it's a team approach to care where people have clearly defined roles, and there are clearly defined workflows. And one main in our collaborative care model, which is the model that has the largest evidence base for effectiveness in treating depression, a key role in this is a non-physician care coordinator who actually coordinates the care and does a lot of the kind of follow-up to make sure people are engaging in care, responding to treatment, and engaging with resources outside of the clinic. So it's a team approach that has very structured communication and clinical pathways that we can talk about. So I think that's really what I mainly wanted to share. We have about 15 minutes I'm happy to answer any questions. I had put a couple of questions on the slide, for you to think about what's working well with respect to mental health resources in your clinical setting currently. What would you like to change about it? And, what is your vision of for your own role in providing these services? But I'm, happy to talk about those questions or answer any questions. Thank you.
Thank you. Thank
Stop
you,
sharing.
Chwastiak. That's a fantastic presentation, and I think the quote from that patient in Jamaica during the media set was really powerful. And sort of caused me to reflect on how good a job I have been doing in terms of screening for mental health disorders for my own patients, especially the ones who were doing really well for a long time, have been doing unexpectedly for a decade, and oh, you're doing so well, everything is fine, your blood work is great, blood pressure is fine, and cholesterol is better than mine, and not thinking about doing a simple screening and missing every case of depression that passes in front of you because they present their best selves when they're with you. And if you just want to pause and so let's see how we're doing, we might be picking this. So I'll just leave the floor open to anyone who has any comments or questions. We have at least 15 minutes for questions, and there's no such thing as a bad question.
I'll give people a minute to think about questions. But yeah, I appreciate that, that it resonates with your own experience, that I think, it's easy when people are severely depressed and, they're crying and but it's the folks who and there are a lot of barriers to sharing with us what they're experiencing. There's shame, there's wanting to please providers, and there's a lot of dynamics. So the importance of screening, I think, can't be overstated. Now we've got a question from Belinda. Please go ahead.
Hi. So it's not really a question, but I really wanted to say thank you for doing this presentation because it really underscores the work that we're doing now. And I know MRF would have their psychosocial team. And so it really reinforces the efforts that we've been making. And I'm happy that, we have such a good attendance. And I'm hoping that the information that was shared, is well received, especially that bit on the brief psychological interventions and equipping really para-professionals and, persons who are not necessarily trained in mental health, but still equipping them with the basic skills to support the persons who come to the treatment and care sites, because that is not really something that was done previously. And so this is really valuable, and I'm really appreciative of this time and space that we get to share and have the information presented the way it was. So I just wanted to acknowledge that.
Great, thanks, Belinda. I don't know, is everyone on the call aware of the work that you've been doing with, it's really wonderful work and some of the training in these interventions and kind of thinking about a team approach.
Yeah.
I don't put you on the spot to share, but it'd be great for everyone to know what you're
Yeah,
doing.
I'm not sure if everyone would be aware. I think it would be persons who are particularly at the treatment and care sites, they would have engagement with me. But I could just say in summary that our intention is to do just what your presentation said, which is to integrate mental health services into HIV treatment and care. Because traditionally what would have been done is that persons who require mental health support, they would be referred out to another clinic, to another location entirely sometimes. And that can be quite difficult for PLHIV to navigate because they may be faced with the challenge of having to disclose again or having to go through the system of just joining a new clinic, the long wait times, interacting with more medical staff, etc. And so we're trying to mitigate those challenges by integrating and enhancing the mental health and psychosocial services that may already exist, right? Because some of these staff members at the treatment sites, they are already encountering these issues and they've already established ways to navigate them. They're already pinpointing persons who are experiencing distress and who need different, like more support, and they have their ways of doing it, but we want to standardize it. So that's the goal of the work that I'm doing. And we do have a protocol that is awaiting approval. And once it is approved, then hopefully it would be implemented at all of the treatment and care sites, so that persons can be identified if they are experiencing any sort of mental health, psychological distress or psychosocial challenges in a standardized way, and that the interventions can be done in a standardized way. So some of the work has already begun in terms of meeting and just creating awareness and building relationships and so, but once the protocol is officially approved, then we really would hit the ground running in terms of implementing it more fully.
No, that's great. That's really wonderful. I'm curious too. I don't know if it's largely physicians on the call, but I'm curious about medication management and, in addition to the work that that your team is doing with psychological interventions. Wanting to just hear if people want to speak up or put in the chat, you know, are you currently treating depression and anxiety? What kinds of medications are available? What are the main challenges in doing this work as physicians who are, you know, managing people who have complexities, right? It's already complex medical management. Just hearing people's experience with treating depression and anxiety in their settings.
I'll go ahead. I policy dogs barking in the background. So at Mrftt, because we're a standalone site, our access to medication for treatment of depression and anxiety sort of depend on what's on. So there's something called the Chronic Disease Assistance Program, by which the government provides certain medications for management of different chronic diseases, including mental health disorders. But it's from a fairly fixed template. So, for example, we have access to SSRIs, we have access to sort of amitriptyline, some antipsychotics as well. But in terms of the frequency with which we choose to treat versus choose to refer, because we have access to psychologists, we tend to refer to the psychologist for management those cases that she believes are specific that require on referral. We tend to on refer to specialists a mental health clinic for program as opposed to try to treat it in the house.
That's helpful to hear. Anyone else want to sort of chime in about their own experience or challenges or wishes for, you know, kind of requests for how things could be better?
I've been treating a few patients who, told me they had depression, but one of the SSRIs, fluoxetine, and most of them tell me like a cloud lifted over them. They say my life has changed dramatically. This cloud has lifted over me. So I mean, it is really rewarding, and I'm happy. I keep them on for about a year, as you say, and I wean them off. It really is rewarding. So I've been screening for depression, and have been seeing lots of people with mild to moderate depression.
Can you share what have you been using to screen?
As I say, we have this chronic disease assistance program. So it's available free of charge. Once you write a prescription, they go to any pharmacy and they can get fluoxetine, There's also amitriptyline also. We add some of it also. So for the depression, the fluoxetine actually works quite well,
Oh, right. No, did you say that you were screening people? I was wondering if you were using a particular scale to screen.
The P2 scale, yeah, I've been using that. Asking them, how they've been feeling, and once we start talking about it, they get into it. So once I initiate a conversation, I've been feeling, have you been losing interest and stuff, they actually initiate more of the conversation and talk more about it. So I just listen. And then they say, Doc, I think I've been depressed for a while, and I really need to do something about it. So that's the way I usually go about it. So just the 2-question screen, that's what I've been using.
Great. It's helpful to hear your experience with that, right? I think it can be very powerful, and people can respond with very little effort on our part. I mean, just a willingness to hear about it, and people will open up, and then really thinking about what can you offer. And it's great to hear that fluoxetine has been so helpful for your patients.
Hi, Conrad here. I think more and more amongst the older PLHIVs, you hear more talk and discussion about depression and questions about how we can look to mitigate the problem and what steps need to be taken. So much so that I know that there is a group of older PLHIVs that are coming together to have fixed discussions about this topic. So I think this is also very timely. I know for myself personally, I've had the privilege of speaking to the psychologist there at Mrftt, and the conversations and the stuff that I've engaged with her, I know it's really helped me. And so I think it would be great for others to be able to have access to this as well. So really looking forward to what the future will hold.
Just also mention that a lot of the cases have been treated as the MSM. So because of the double stigma associated with being MSM and HIV positive, I mean, that really affects them. So they haven't come to terms with being MSM. They have come to terms with their HIV status. So again, I think we need more work to be done in that field.
Yeah, I appreciate that comment. I think there's a lot of barriers to effective medical care, mental health care, just social support, and being able to recognize multiple types of stigma and how they, the intersectionality across different types of stigma. So, that really speaks to being able to not all interventions or approaches are going to work in all circumstances, and really trying to tailor to the people you're working with or the person in front of you, I think is a critical piece of this. So thanks for that comment.
Hi, maybe. Thanks so much for this beautiful discussion. Let me just add that oftentimes just talking to a patient, an opening statement like, "How are you?" opens the conversation. And I think this emphasizes the importance of maybe the same person attending to the same patient oftentimes, because then you come to understand them. I remember one time when I asked somebody, "How is your son?" And he was so surprised because the question he asked me was, "You mean you remember that last time we talked about my son?" And we've been friends up to this point. And then the other thing that is a big problem is sometimes the referral system we have is generally to a psychiatric clinic. And going to a psychiatric clinic has got its own stigma apart from going to disclose again. So some people will tell you point blank that there's just no way they are going to crazy people, mad people's clinic, and they will simply not go. And I think you asked about screening, and when Belinda was at MRF, who asked the psychologist, she gave us quite a few of the, introduced everybody to the PHQ-9, which some members of staff have been using quite often in terms of screening patients. And I'm glad you've alluded to the point that if you could just use PHQ-2 and GAD-2 initially, it would also help you to determine who requires PHQ-9 and maybe somebody who requires treatment. But just going back to where I started, just talking to people makes a very, very big difference.
Thanks for those comments. And I think you're right about the relationship. I think that's a big part of the challenge if people are coming in and they see a different provider. I think it's true for all care, but for mental health care in particular, the relationship itself is therapeutic. So being able to have that connection over time can be really important. And so thinking about the clinical workflows, how is that possible? Is that possible? Or how can you have more of that? It's such an important part.
And then the other point is that we often talk about, oh, this will take a very, very long time. The fact is, not everybody has an issue that requires very detailed evaluation. However, if a patient requires that they stay with a physician for 45 minutes to 1 hour, let it be. It's for the better, rather than they stay for 5 minutes, but they don't benefit at all. I know my colleague, Dr. Boy, sometimes stays with patients for quite a while, and he deals with very, very tough people. And oftentimes, the kind of people he sits with, you cannot see them sit with them for 5 minutes and you think the job is done. So there's also, I mean, every patient is different. And if they require longer time, give them. The people come in and all that they require is a prescription and they go and fill it at the pharmacy and they go home. That compensates for the time you spend on somebody that we might think is not necessary. But at the end of the day, what do we gain? What is our success rate by sending people in a hurry? I mean, this is not anything that happened at an HIV clinic, but when I was working in primary care system, I sat out of a doctor's office and counted, and within 45 seconds, somebody went in and walked out with a prescription. That was really quick. Thank you.
Thank you, Dr. Musa, for all those comments. And thank you, everyone. It was a wonderful presentation and conversation. I think especially for the listening and the returning for presentation of the Chwastiak. Thanks so much for agreeing to do this. And really, it's always, I think, most challenging and encouraging to get your mind around boundaries for dealing with. Understand that there is a way forward. We can help our clients with transform this well-being. So it's just a stuff here. So for it enough. Again, thanks everyone for coming out. I think this reinforces how much our interest rate, how much commitment there is among education providers to ensure that the needs of our clients is to everyone, that's it for us again today from Mrftt HIV. Dr. Boys, and everyone be safe and be well. Take care.
Hey, thanks everyone.
Thanks everyone.
Thank you, Greg.